Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today we have the pleasure of being joined by Dr. Eric Secemsky, Associate Professor of Medicine at Harvard Medical School, Director of Vascular Intervention at the Cardiovascular Institute, and Section Head of Interventional Cardiology and Vascular Research at Beth Deaconess Medical Center in Boston, Massachusetts. For those of you not in the know, this is a world-class institution I've had the pleasure of visiting and collaborating with. Eric is a renowned interventional cardiologist and vascular interventional specialist with very impressive credentials. He oversees vascular services across a network of hospitals and trains fellows in endovascular procedures with specialization in complex arterial revascularization, renal denervation, we're going to come on to that, and pulmonary embolism interventions. Eric pairs his cutting-edge practice with an impactful research program funded by the National Institutes of Health, the NIH, and other leading organizations. He's the national principal investigator for many cardiovascular clinical trials, particularly on research into device safety, disparities, and patient-centered care. Through his collaborations with startups and established companies in cardiovascular innovations, and as an author of over, wait for it, 270 publications. I don't know how, I've had quite a few, and I'm a few years older than the good doctor. I don't know how you get to that number. He probably never sleeps. But he's deeply engaged in shaping guidelines, advancing vascular research, and collaborating across institutions to improve patient outcomes. And whilst his work is all-consuming, Eric ensures a good work-life balance with music and lots of travel with his family. So I'm sure you're going to enjoy this conversation with the good doctor, Dr. Eric Secemsky. Thank you so much, Eric, for joining us here on the podcast.
Jonathan, thank you very much for the invitation and welcoming on the show. Thank you.
You're very welcome. So you've worked, no big surprise for a Renaissance guy, you've worked with the New England Patriots, who play something that you chaps call football. I lived in the States for many years, so I'm sick and tired of doing those jokes. But you've done preseason physicals and screening for conditions like obstructive sleep apnea. What was your experience working with this group of professional athletes in this way? Must have been very, very different. And are you a football fan?
Oh gosh, great questions all around. This was something that we were doing more earlier in my career as a self-appointed physicians to the Patriots, as I like to say. We had this nice program when I was over at the Mass General Hospital across town, and I will say first to the last part of the question was football in America is kind of America's sport, so it's almost sacrilegious to say you're not interested in American football. That said, I wouldn't say it's at the top of my list, although I have a lot of loyalty to my local team. I grew up in Chicago, and so we have the Chicago Bears. But when I moved over to Boston, we had this opportunity to participate in screening these football players, American football players. And for many of you or hopefully caught a game or see one of the London NFL games that they bring over to the UK occasionally, these are not normal human beings. These are superhumans, if you can imagine. And it was quite the cute opportunity to be able to come in there and provide preseason screening to make sure everyone was fit to move forward with their intensive program leading into the full season. And I always joke because the one job I had was to screen people, as you mentioned, for sleep apnea. And the requirements were, do you snore at night? Is your neck of a certain girth? And is there BMI over 30? And if you can imagine, it was about 3 for 3 for every football player. We pretty much had an entire team of sleep apnea patients because they met every screening criteria. So I always joke that we need to be more specific with how we screen for sleep apnea for the NFL at least.
Yeah, it's kind of like with the whole thing with BMI. BMI goes out the window if you've got athletes because muscle weighs more than fat. So these
Absolutely.
guys have very high BMIs, but they're fit as a flea. Actually, the home of the NFL in London is at the stadium of the team that I support, Tottenham Hotspur, and to watch the football, what we call the football pitch, it's on 3 metal trays and it slides under the stand.
Oh, no way.
It's a sight to behold. And then, of course, the changing rooms for the American football players are bloody massive. There's hordes of them. It's like an army. But yeah, I have watched games, but yeah, we'll talk about that some more another time. I mentioned that you're deeply involved in designing trials for cutting edge devices in your specialty in interventional cardiology. I've done a few of these myself in my areas of interest in surgery, and they're tough to do. It's tough to do designs to design device studies. Can you explain to our audience some of the challenges in designing trials in this field, and maybe highlight a couple of innovative devices and strategies that you've seen developed?
Yeah, really great questions. I think one thing that we struggle with in the U.S. is we're tied to the law of the regulators as in most countries, and so depending on the type of device that you're interested in bringing to market, um, really constitutes what the design looks like. And then the other challenge we have is we have a device on the market and we need more evidence. How do we design a trial, and more importantly, how do we fund a trial to answer an important question? And then again, that the NHS and the UK has done a good job of finding pathways to fund trials, in my opinion, and I'm sure others can comment on that. And I have some very close colleagues in the vascular space doing really important work. In the US, we have kind of three ways to do a trial. One is a company sponsored trial. Two is a self funded trial, which is probably the least likely to happen. And three is a nationally funded trial, which is incredibly cumbersome and challenging to get. And so, each design requires a different type of ask. So I'll give a couple examples just to kick off the conversation. So we're working right now in the US to bring these drug coated devices for the peripheral artery. So we have these drug coated balloons that have medication on them, very similar to a drug coated stent, if you're familiar with someone having a heart attack and a stent
Yeah,
placed. And we
totally.
don't have we have this real problem of patients getting amputations when potentially there was some prevention we could have done to keep the arteries open longer. And so we're in this long-standing process of getting these drug-coated devices approved in the U.S. Now, this is one of the ones that fall into a company-sponsored regulatory trial. So for these trials, we have to design a trial that meets the regulators' needs. So it needs to be a randomized trial compared to a predicate device. But we also need the company who's sponsoring it to have input. And we have to think about the patient and what this looks like in the market at the end of the day. And so we have been working for years to find the right type of endpoints to study that still capture what's important to the patient and the regulator, but that doesn't make the trial a 10,000 person trial that takes 10 years to undergo, because we don't have the funding to do that. And also, things evolve over time that we may not be studying the device we're using anymore. And so we've been working really hard to create streamlined endpoints, and we've been introducing other statistical methods to help with some of the efficiency of these trials. People are getting more familiar with the idea of something called a win ratio, which is this trade off of you might win on one endpoint of a composite, but you might not win on the other one. And it gives you a statistical way of evaluating each of these endpoints individually. And so the design of these trials are really coming along. The technology is phenomenal. People right now are innovating at a degree that amazes me, finding new ways to package medications on these balloons, finding new ways to deliver therapy to locations that are really hard to approach. So really an amazing time in innovation. So that's one example. I'll pause there and I can give you a few more if interested on what this looks like.
Sure. I mean, I just want to make a point. I sometimes think as a profession, we do not do a good job shouting from the rooftops. I was at a dinner the other day with a bunch of actually retired professional football players, guys I've known for decades. One of them, and it's in the public domain, so I'm not breaching a patient confidence. In fact, he's done a podcast with me, Glenn Hoddle. You may not know the name. He played for our team. He was manager of our team. He played for England. He managed England. And on his 60th birthday, literally, he was in a television studio and he keeled over backwards and he was in full cardiac arrest. Thankfully, there was a light. He was doing football commentary and there was a lighting gantry guy there, Or was he a sound guy? I'm blanking. But thankfully, he was CPR trained. He grabbed an AED. He was taken to hospital. He had he had bypass surgery and implantation of a defibrillator. You think about all those steps from the AED to what he had done surgically and these implantable. If that had happened when I qualified for med school, he wouldn't be with us now. And there was another guy there who had an abdominal aortic, a thoracic artery aneurysm. You know, our world has improved dramatically. I just wish, as a profession, we shouted from the rooftops and thanked the people in the device and the pharmaceutical industry, without whom we couldn't do all this stuff. So I want to get on to a really specific one, which I'm very interested in. You had a study, post-marketing surveillance of inferior vena cava filters among US Medicare beneficiaries. That's older people, 60, 65 and above. It was a groundbreaking collaboration with FDA using real-world observational data to rigorously evaluate device safety and outcomes. Can you talk to us about this work in the context of prior actions by FDA to remove IVC filters from the market because there was some issues?
Yeah, that's a great segue because this is the other world of clinical trials in the US also from the regulatory perspective is these were devices that were able to come to market with very little evidence. And again, this happens through different pathways. Every regulator and country wants to be at the cutting edge for science, and we balance the safety and efficacy that we need to prove for a device to get it to market versus the speed to market, and being one of the forefronts for supporting device innovation. And so IVC filters is a storied product in the US, which was approved many decades ago out of a really reasonable concept. And for those not familiar, the idea is if you have a clot up in your lower legs, that's called a deep vein thrombosis, it has a risk of traveling to your lungs and causing significant risk of a death or a cardiovascular event. And so if you interrupt that pathway, you put a little umbrella in the big vein in the belly called the inferior vena cava. We could capture these clots if they are to dislodge, and we're all good. And we have now prevented event. But the things that we forget is we haven't shown what type of event reduction these devices can do because the evidence wasn't really there. And then second, we didn't pay enough attention to what are the long-term sequelae of leaving these devices in place. And originally they were permanent devices and they caused local problems that can clot off. They can move beyond the vessel into other locations nearby. So then they made retrievable IVC filters. Makes more sense, right? You leave it in as long as you need it, and then you take it out. And what happened with those is people forgot to take them out. No one did their job. So people would come in and they'd get it placed and they walk out of the hospital, and we're not good at tracking these retrievable implants. And they'd go about their business. And then 10 years later, they come in and it's now dislodged into the aorta. I pulled one out once that was sticking through the inferior vena cava and into the aorta. It can go into the bowels. It can break off and migrate into the heart. And so all these issues were happening, but they were happening at a small scale. And this is the problem we run into is we could have real events that are happening, but because the number of implants and the amount of time it takes to get there, we're missing these signals. And so, we have worked really closely with the FDA. We had done a lot of work on the paclitaxel safety for people who are not in the vascular space. There's a concern about the safety of these specific drug on stents and balloons. And so we formed a relationship and we said, we need to do a better surveillance of how these IVC filters are being used. And to your other comment, the FDA had been kind of like you mentioned before, shouting that physicians need to do a better job taking these out. There's been warnings about the necessity to remove these. And yet when we did this whole exercise with the FDA, it was around 15 to 20% of IVC filters, depending on the year, being removed out of all being placed. So we are clearly not listening to guidance and not following the rules. And the nice thing, again, is we have, like many other countries, we have a national insurance, Medicare insurance that covers everyone over the age of 65. And from that, we've created these research databases that when these rare events are happening, we can still catch them. And that was the key to this also, is we had enough patients in here and enough time to follow them. We could get some real estimates on when these adverse events are happening as well.
Yeah, yeah. You know, unfortunately, no, we live in at a time where people want perfection. They want, things that will resolve risks of human morbidity and mortality, but they do not want the device or the drug in and of itself to carry risks. And I think we need a changing mindset so that people, and again, I think that falls to our profession to do a better job educating people. Moving on to a different topic, because I think we could probably talk all day just about IVT filters. It's something I'm fascinated with. You developed one of the first hypertension centers dedicated to the management of resistant hypertension, including pioneering work with renal denervation. And I remember that storied journey from a great idea to, oh God, no, this doesn't work, to, oh God, this does work. So can you walk us through how this program was conceived and how it's helping patients with complex hypertension cases now?
Yeah. So this is a labor of love. We about 4 or 5 years ago, as we were growing our center and investigating new therapies, we were realizing the real plague of hypertension and how we weren't meeting our cardiovascular benchmarks because of the real prevalence of uncontrolled blood pressure. And in the U.S., 1 out of 2 adults in the U.S. has uncontrolled blood pressure, and more than 30 to even 70, depending on the estimates, are not compliant or adherent with their medications, are not meeting their blood pressure goals. And we've had 40 medications come to market. We all know about losing weight and moderating our alcohol use and exercising, yet none of these strategies are working. We create poly pills, we do all these different initiatives, and still we're running into the same barriers. So as we were developing the idea that we need more comprehensive care for the hypertension patient, renal denervation started to get its next resurgence. And we saw a really nice opportunity where we can mirror our interest in hypertension with a new therapy that's coming to market. For those who are not familiar, renal denervation is a really cool procedure in concept, and we're seeing hopefully the benefit of it in the long term for clinical practice. But this is a device that came out of the early worlds of hypertension management, where there is surgical sympathectomies being performed, where they would cut off the nervous system to the kidney arteries to try to lower blood pressure. And this was before blood pressure medications, and it worked, but it was morbid. As you can imagine, it was a big surgery for a very prevalent condition. And as soon as the first real blood pressure agent came to the market, and followed by several others, there was really no need for a surgical treatment like this. But it did show you that it could be effective. Fast forward to the 2000s, we've developed a catheter that can go in the kidney arteries, apply heat, and destroy those same nerves that were raising blood pressure safely to get a blood pressure response. The problem is, how do you design a right trial here? And so the original trials were 2 people walk in the office, both of them have hypertension, one gets renal denervation, one stays on the medical therapy. Boom, we've got a great reduction in renal denervation, looks as good, if not better, than medical therapy, and we should be done. But then people caught wind of the fact that, there is this idea of being monitored in a trial, and understanding that we needed a sham procedure and a control arm. So we called that Hawthorne effect, that people act better, take their meds, exercise more when they're in a randomized trial.
Trading
So
and
then exactly. And so all of a sudden we had this trial in the mid 2010s that it was the first one to randomize to a sham controlled procedure. So they'd go in there, put in an IV, pretend to do the procedure, but make no changes to the patient's inner anatomy. And it turned out that both people dropped their blood pressure by 10 points. And I could go into the nuances behind that. I think if you look behind the scenes a little bit, it wasn't necessarily a failure of the device, but many of the people in the non-device arm took all this medication, and they had this amazing drop for a sham procedure. Their blood pressure shouldn't have changed, and it went down 10 points. So there was a lot of challenges with the design of the trial, but it shut down the whole space. Again, fast forward, and just for the sake of time, we're now 6 randomized trials into the newer devices with sham controls. And we're seeing, again, most of these trials are at about 6 months as the primary endpoint, a nice 10 to 15 point reduction in many patients, a 5 to 10 in the other patients, reduction in blood pressure. And as you get to 1 to 2 years, you get to about 15 to 20 point blood pressure reduction. So we, in Europe and beyond, they've had this available for some time. It just launched in the US in 2023. We've been one of the highest volume centers, and I would say on average, we're getting our patients about a 20 point drop in their systolic blood pressure at 6 to 12 months with this procedure, same day procedure. So, really interesting concept. But more importantly, I care about the disease state, like you said, Jonathan, and the fact that we need to really get blood pressure under control to make a dent in cardiovascular risk reduction.
We also need to start diagnosing the condition earlier. Someone once told me that by the time it gets diagnosed, it's, you've had intimal damage, hyperplasia going on for 12, 13 years, maybe, and with obvious end organ implications. So we need to do a better job. And of course, the problem with hypertension is it's not like you've got a pain. You're treating a number. And I remember talking to my dad about it, bless him, and he was very resistant. He says, I don't know why I'm taking these pills. I don't feel any different. And trying to explain to him what would happen. And people don't react well to, preventing an airplane crash. They don't think like that. So we got to do a better job of it. But
That's a great comment. And that's the reason why they call it the silent killer. But the worst conversation you have in the clinic is they come in, their blood pressure is elevated. They say, I'm going to write you a prescription for a blood pressure medication. And they say, great, how long do I have to take it for? I'm like, no, it's not like an antibiotic. It's not, this is your new life. And I'm like, go through the exercise of every time you brush your teeth, take your pills, that type of thing, or put it on your phone, a reminder. But people have a real hard time being on a medication. Anytime you have a sensation of anything, you want to blame the medication. And then it's easy to forget, and my wife, who's a physician, I'll throw her under the bus. She's terrible at taking her medications, and I have to remind her, and she's a doctor, and I'm like, you're letting her field down. So,
actually, without mentioning any names, my medical school class, the number of my colleagues who have never had their blood pressure checked.
Oh, yeah.
And in fact, I lost a very dear friend. I do a lot of colorectal surgery. I lost a very dear friend to colorectal cancer. The silly so-and-so never had a screening colonoscopy, recommending them to everyone else, never had one himself, and died of a completely treatable disease. But there we go. So moving on, you're working now on a study entitled Data to Enhance the Evaluation of Cardiovascular Devices, examining the safety and effectiveness of several high-risk cardiovascular devices used in the US. How will these impact our understanding and use of new medical studies?
I think the key that we've been working on is trying to use the evidence around us to, detect signals of harm or potential safety issues earlier than we have done a good job of. We run randomized trials, are not powered for these smaller events, as we mentioned. You go out and we rely on the physician to call the regulator or the company and say that device didn't deploy right, or the patient had an adverse event, and we think it's from the medical device. And if you don't go through that whole exercise, it never gets captured. And so we're really working on building an infrastructure where we could passively use medical data. A lot of our data comes through billing claims, insurance claims for events or hospitalizations. We have newer companies that are aggregating electronic health records and then detecting where there's deviations from what would be expected from an event. And I think that is what's necessary. And we are so fortunate in 2024 going into 2025 to have the technology and sophistication to do this type of work. It just requires a little bit of innovation and a little bit of medical guidance to make sure that we're picking up the right signals that actually are meaningful. But again, I think we'll be a healthier and smarter population if we can build out these infrastructures that exist in the background.
You also made the point when talking about renal denervation about doing a sham procedure, and I've done a lot of device trials, and I struggle with the ethics of a lot of these things, especially in surgery. What? I'm sorry, you want me to do what? You want me to put a patient at risk of anesthesia and do a sham operation? I'm really going to struggle with that. And I think we need to move to a more observational type of approach. There's the classic, isn't it? Everything for evidence-based medicine has to be a randomized, double-blind, controlled, placebo-controlled clinical trial. There's that great paper in the British Medical Journal that points out that there's never been such a trial to prove that parachutes actually prevent gravitational induced injury. Sometimes I think we need to be a wee bit smarter. So I'm sorry.
I want to make one comment on that, if you don't mind. If you pull up, and I encourage the audience to pull up, the British Medical Journal has a Christmas edition every year,
Yeah.
And 7 years ago, we did the parachute trial.
You
And I
did
wanted
this,
to,
so that's
we
right. You did
did
the
that.
follow-on. And
So
I love,
we
man,
went,
I love that.
I went on a plane. We were tasked, my partner, Bobby A, was the senior author, and we were on planes across the country. I'm flying with my family. And
Yeah.
our quest was to find people near us in the middle of the flight at 30,000 feet and say, would you be willing to be randomized to a parachute or not if this plane, if you had to jump out of the plane? And so we got a lot of attention for that article, but that came out of our research center.
I hadn't put two and two together, but I fly airplanes as navigation. I've been flying since I was a kid. And I've actually signed up to do parachute jumps 3 times, and I've chickened out 3 times. But I loved that work, man. I thought that was brilliant. Good on you. So wow, I hadn't put 2 and 2 together.
Yeah, that was a good one for our group. Yeah.
There's the picture of people like jumping out of an airplane on the ground because you
I
got
will show you that. I have that. If you look in the appendix, I'm one of those. We went down. We had to rent from an small airplane out in Martha's Vineyard, which is off the coast of Boston, Massachusetts. We rented these small red propeller planes, and we each had to replicate jumping up with them. So our coordinator is the one that made it into her picture made it into the journal. But we have a series of these. Yeah.
270 publications. Listen, my most quoted publication, never mind anything vaguely clever I did, my most quoted one was a review of 42 things I'd removed from people's anorectums. And, you've got 270 very learned, very carefully thought out things, but I bet that's the one that people are going to remember.
That is right. That is right. I'm fine with that in the end. That is so cute. I'm going to pull up that article also after this.
Priceless. So I saw something else on your CV that got me thinking. I believe that autopsy rates have been declining globally, and without them, maybe we get inaccurate data on disease incidence, and that impacts how we provide services and think about creating services. You published a paper this year entitled Death Certificate Documentation is Inaccurate for Most Patients with Acute Pulmonary Embolism. Tell us about it.
Yeah, what an astute pickup. I think that's a great comment. We've, definitely struggled where, and again, all of our observations, everything that we've just talked about that we want to do effectively requires that the endpoints that we're looking at are captured correctly. And, in our healthcare system, if you have a hospital death, you get on the phone with the coroner and they go through some questions, and their big questions are, was this expected or not? Because if it was, considered an accident or a homicide, they would get involved. And then they want to know the cause of death. And you have this first year untrained junior physician making the phone call, and they're saying, we need these certain criteria to be captured on the death certificate, and everybody ends up dying from cardiac arrest.
Yeah.
But what's cardiac arrest? As we all know, that is an omnibus of a condition which includes a heart attack, ruptured aneurysm, a pulmonary embolism. And so, we have been really trying to understand as we've been bringing these catheter-based procedures for pulmonary embolism of, are we doing good? And how do we, when we do these trials, how do we capture the right endpoints? And you can't just say anybody who died because of a pulmonary embolism if they had a PE, because many people die because they have controlled cancer or sepsis, or they had a really complicated surgery. And the pulmonary embolism was just one of many things that happened during that hospitalization. So we went back and we said, okay, how are all these deaths, categorized? And let's look through all the charts and really figure out what was the cause of death. And there was this incredible discordance. And so, this just speaks to building that infrastructure for doing effective research, is getting everybody on the same page of how do we classify an event. And you got to be forward thinking that this could be helpful down the line for a project, not just at the moment of I'm checking my box and getting the patient through this process. And so, that was really a call of action for us to be thinking a little bit more about what we're putting into the literature.
Yeah, and also I'm a big fan of more autopsies rather than less. I think great learning experience for all of us. But yeah, that's interesting. And I wrote a paper years ago on Boerhaave's syndrome, and people who esophageal tears, people who were, it must have been a heart attack, severe chest pain, drop dead.
Yeah.
So
Absolutely.
you mentioned below the knee critical limb ischemia and drug-eluting balloons. A while back, I was collaborating on a technology to address that problem. Sadly, it didn't pan out. Very, very expensive to develop new technologies, and we just couldn't put the cash together to do it, and the experiments weren't quite going the right way. Another recent paper of yours was, I believe, a state-of-the-art perspective entitled Contemporary Practice Patterns and Outcomes of Endovascular Revascularization of Acute Limb Ischemia. Can you give us like a 30,000-foot view with a parachute?
This is another good parachute one, but we often find these patients, and we differentiate the disease in the legs of either chronic or acute. And chronic, we have time, we want to move quickly, but we also are planning. We can bring them in not through an emergency room. Whereas acute limb ischemia, for those not familiar, is a sudden arrest of blood flow to the leg, and this is typically done because of a clot, maybe travels from the heart and lodges in the artery. Sometimes it can be caused because of a procedure, and the procedure results in shutting the artery down. And this is incredibly morbid and potentially fatal. The prevalence of needing an amputation from these are quite high, and that can lead to also death on the earlier side. And so, a lot of our innovation in the below the knee space has covered the more chronic disease states, but we've also seen these newer catheters and devices for the acute disease states. How do we get these clots safely out of the arteries without having to do a large surgical exploration? And so there's been different techniques, whether you can vacuum it out with a large thrombectomy, we call a catheter, or whether you can grab it with a cage device and just grab and take it out of the vessel. And so there's many different methods now, but just like much of the theme of what we're covering here is the evidence has lagged clinical practice. We think we're doing the right thing. We have some anecdotal experiences. I can show you a really nice case if you're interested, but are we doing on the grand scale of things the right thing for the patient? And so we leverage the national registry to really understand how these new devices are performing. And overall, they're hitting the benchmarks of where we would put rates of adverse events compared to traditional surgery or even just doing something medically like a clot buster. But again, it speaks to the need to continue to evaluate our technology, because these are coming to the market quickly, and then we're lost with, oh, this worked really well for me once, so it works, or this didn't work really well for me once and it doesn't work, and I'm going to go back to what I've been doing for the last 20 years. And so trying to thread that needle of getting people an understanding of where their numbers should be and roughly how they look at a national scale. And if you're around that area, then you should probably continue going. And if you're really off, then reassess whether you're doing the right thing for the patient.
Yeah, it's the classic thing, isn't it? There's evidence-based medicine, but I don't need that because I've got my experience to guide me.
Well, yeah,
It's always
absolutely.
it's always the last case. So sadly, we're running out of time, but there's a question I always like to ask folks, that if you came across a magical genie as you're wandering around on Martha's Vineyard, and you kicked one on the beach, and kicked like a lamp, and out popped a genie and said, Eric, I've got three wishes for you. What in your area of healthcare? What might those wishes be?
Oh, those are easy. Um, One is I would get everybody, and again, I'm going to speak a little bit to the US, but everybody a trusted primary care physician early in their life that they're obligated to see. I think most of our chronic issues right now that I deal with, and I deal with secondary prevention, they've already had an event that I'm trying to, is could be solved if we get everybody equitably access to healthcare early on. And it's a continued struggle in our country, and I'm sure elsewhere around the world. Two, I would ask for a healthy pot of money to do all these clinical trials correctly and how we wanted to do it. And I think, again, we didn't get too much into it, but one of our biggest struggles is getting public funding for clinical trials. It's just not a lot of interest in that right now. And then going to companies to fund a trial after the device is already on the market. They don't want to do that either. So, I think that would be my number two. Third, I would be ask the genie to make me about 4 inches taller and a little bit more hair. And I think that would last me to be pretty happy for the next 2 decades. So if they can get me that, I would be a happy man for the end of my life here.
Well, thank you very much for those goodies. Yeah, getting work funded, and access to care. It's funny. I practice both in the United States and the UK. And I've had the privilege of operating all around the world, and every country's got its issues. The United States is access to money to pay for the clinical care. In the UK at the moment, we've got resource limitation because the payment from central government is an issue because there's competing requirements. And in sub-Saharan Africa, it's are there any doctors, and is there a infrastructure to get to them? Wouldn't it be really nice if clever people from every country could get together and say, here's what we do well. Is it relevant to your country? Let's try deploying it. That would be nice, instead of a lot of hyperbole and chest beating and saying we're the best. None of us are the best. We can all do better. Dr. Eric Secemsky, thank you so much for being with us today. Total delight. Really enjoyed chatting with you, and I hope we can do it again soon.
Thank you very much. It's an honor to be here, and I appreciate everybody listening. Thank you.
You're most welcome, Eric. So for the folks listening in, please check out the archives. There's many, many more really interesting discussions. Unfortunately, you have to put up with me, but there's a lot of really great guests. And please subscribe on Spotify or Apple Podcasts or wherever you get your podcasts. That way you won't miss an episode. Tell your colleagues, tell your friends, like us on social media. You know the score. And join us next week for another fascinating episode of the EMJ podcast. Until then, I'm Dr. Jonathan Sackier. I thank you for listening. And please, everyone, stay safe, stay well, stay curious. Bye for now.